welcome to day 2 of joining our voices, envisioning the future of serious illness care, which is a week-long symposium. This is our first one, so we're so excited about it, and we are through the North Carolina Serious Illness Coalition. We are a coalition of individuals throughout the state that come together to discuss how to improve care for those facing serious illness, not only patients, but the families, the caregivers, all those people involved. So we're excited to have you here. I'm Beth Rosenberg. I'm a licensed clinical social worker as well as program coordinator for a program called Your Care, Your Choice through Atrium Care. And my team provides education to staff in the community about advanced care planning and serious illness conversation. We'd like to kind of start off by just showing you a couple of slides. We're going to do introductions to the panelists in just one moment. But today we're going to talk about exploring strategies for treatment adherence, how technology and other new ideas can impact the way we think about serious illness care management in the home. So as we're going through the presentation, please feel free to write questions in the chat. Or maybe at the end, we'll have a few minutes, we'll open it up to some questions, but definitely we want to make sure you guys have the opportunity to ask questions that we may not address for the short time that we're all together. I'm sure there are a lot more questions than we have the time for, but hopefully this will lead to continued conversation. So just important terms to know, adherence and compliance. I think some people get confused about what the difference of the definition is actually. So adherence refers to treatment goals in which the patient and provider mutually agree on to a treatment plan. It encompasses patient freedom of choice and does not blame the patient for non-adherence. And then compliance is a term that's, I think, an older one. I've been in the medical community as a social worker for 20 years. I'm using adherence more nowadays than the idea of compliance, but it refers to treatments which are determined by a provider alone. Non-compliance implies the patient is opposed to the provider's treatment plan, but we understand that that's not the case. Most of the time, there are a lot of issues behind why people aren't able to adhere to the doctor's treatment plans. And then the impact of adherence and non-adherence. The effects of non-adherence are that in the United States, 3.8 billion prescriptions are written annually. 1 in 5 new prescriptions are never filled, and of those, 50% are taken incorrectly. This correlates to $100 to $300 billion in healthcare annual spending. The benefits of adherence are improving adherence. It can lead to improved chronic disease outcomes, reduced ED visits. It can reduce mortality and healthcare costs. And as a social worker, I find that when people are able to understand the medicine and the adherence, they have a better relationship with the medical team that they're seeing. So again, we are going to, those are all the slides, so we're going to go straight to the panel. And I would just love you guys individually to introduce yourselves, just tell us what currently you're doing, and then we'll just start off with questions. So I'd love to start with Dr. Marico Dove.
Thank you for having me. So I have 18 total consecutive years pharmacy experience as a pharmacy technician, a pharmacy intern, and for the past maybe 3.5 years as a pharmacist. My experience includes working at FQHCs, including Lincoln Community Health Center and Advanced Community Health. And I am currently the pharmacy manager at the prestigious North Carolina Central University's campus pharmacy. While at Advanced Community Health, for the 3 years that I was there, I was able to implement clinical pharmacy services where the pharmacist was embedded in the clinic, and we were able to conduct billable encounters such as Medicare annual wellness visits and continuous glucose monitoring visits.
Great, thank you so much. Linnet, Steinman.
Hey, good morning, everybody. I am a diabetes educator. I have been in that field for approximately 30 years. I have 2 kids living very, very well with type 1 diabetes. And I love what I do. I have that opportunity to be able to sit down and talk with patients, and really try and figure out why maybe some people are not doing what they have been asked to do. And there's always a lot of different reasons. I currently work at Living Children's Hospital, so I work with the young ones, but I have lots of experience with pregnant women living with diabetes, whether it's gestational or type 1, type 2, and also people diagnosed with diabetes as an adult. So I am lucky to be able to do what I do.
Thank you so much. And Dr. Anthony.
Good morning. I'm currently serve as the CEO and founder of a company called iRxReminder. I also am an adjunct professor at Kent State University and I'm a senior lecturer at Kent State University and an adjunct professor at the City University of New York School of Professional Studies. My research has focused on medication adherence for about 15 years. And before that, I was focused on dementia. So I've been working with serious chronic illnesses for about 25 years. Until a few days ago, I was serving as the Secretary General for the International Society of Geron Technology, which is focused on using technology to help improve the lives of this population.
Thank you all so much. So we'll just start off with an opening question, and that is, why is adherence important? Dr. Dove, we'll start with you.
So you had a very nice slide about the benefits, I believe, of adherence. So as a pharmacist, adherence is very important because the more patients are adherent, then it definitely can improve outcomes. So that's just one of the main reasons why I think it's important. It decreases hospitalizations. It decreases the cost of healthcare.
Thank you. Linnet?
So in the population that I'm working with right now, it definitely decreases the readmission rates, costs for the hospital. I mean, and the hospital is always looking at that bottom line, but it improves their long-term outcomes. So as I said, my kids live with type 1 diabetes, my youngest for 30 years, and he has no signs of complications. And that's something, there's something to be said for that.
Thank you. And Dr. Stearns?
Well, for me, I equate high adherence with independence. So when people are staying on their medications and taking it as instructed, they're able to achieve and sustain independent living. And it's only when people become non-adherent, stop taking their medication, that there are problems. So for those living with mental health conditions, it might mean that they're in danger of losing their housing or their employment. And for older adults, it may mean that they lose the place that they've lived for many decades.
Thanks for that. And just not that I'm on the panel, but in the work that I did in the hospital for so many years, to me, those people that were able to be more adherent, there are a lot of reasons behind why people are not their fault, but their quality of life is better. Their emotional, their physical, their spiritual, all the things that encompass who we are end up being a much better life for them. So again, that's why I'm so excited that we decided to have this as one of the days. So thank you guys so much. The next question I'd like to start off with is, what are the barriers, or a barrier or some barriers that you see about people being able to maintain adherence? Because I think, knowing what I know, right, that's one of the bigger issues in the medical community right now. Linnet, can you start off with that?
Wow, laundry list. So we only have an hour, is that right?
I know, that's the biggest question. I want to get that one out of the way first. so that we could ask the other ones, right?
So again, with diabetes is very much a self-managed disease, and it's prevalent in the US. So with diabetes, people need to understand, what is diabetes doing in their body when it's uncontrolled? What is the definition of control? Some of my patients just don't have a good health literacy. And that has nothing to do with education, as most of you guys know. It has nothing to do with education. So if they do not understand why we are asking them to do what they need to do, there isn't that impetus to do what they need to do at home. So health literacy is a huge issue. Access, costs of insulin, holy smokes. I recently got a prescription for somebody, 5 insulin pens, which is only half of what they needed for the month, was $610 with no insurance. And, if there's a lot of uninsured and underinsured individuals. So with our high deductible plans, people are, as Dr. Stearns was talking about, going into bankruptcy and losing some of their basic needs like housing. And I do feel very strongly that if people are able to understand the things that they need to do as far as diabetes, and they will feel better. They will have a more fruitful, productive life, with their families, with their friends, with their work life. They will have a sense of community, and I think all of that just makes for a happier, healthier human being.
Thank you. Dr. Stearns.
Well, I think the earliest work in adherence really focuses on things like social cognitive theory, which is where about 70% of a non-adherent event is forgetting, and then there are other deterrents. But when we look at longer term adherence, I think people are making decisions about getting off their medications on their own, and so my work now focuses on partly on health literacy, but also on helping develop cognitive prosthetics that help the healthcare team be aware. First, the person being aware, and then the healthcare team as a backup being aware that that person is now non-adherent. For people who can't not take a medication for 24 hours makes a difference, for bipolar disorder or diabetes in some cases. So these are so for me, it's a helping people to make better decisions about their own behavior when let's just leave it there.
Thank you. Dr. Dove.
So I've seen some of the same barriers as Dr. Stearns and Ms. Steinman. Hopefully I'm saying that right. But additional barriers that I've seen in the community healthcare setting and in other settings, I would include cultural and individual beliefs, and as well as a fear of adverse effects. And I find that some patients, they're not non-adherent because they don't want to be non-adherent. There's a lack of understanding, as I think the others have alluded to. But those are just some of the barriers that I've seen, which plays into, are we addressing those barriers? Are we meeting patients where they are?
So these are all great responses. And as far as, the cultural piece, I think in the recent few years, thankfully, a lot of hospital systems are implementing more education through staff about understanding culture, how culture plays a part in healthcare, how we think about what's going on in our body, as well as the reasons why certain medications. I'm sure those of you who are in the audience, you know, a lot of times people come in saying, hey, I'd like to do this medical treatment, and it may not even be a prescription, it may be herbs and other things, and to be able to have that insight to comfortably ask those questions. A lot of times people don't feel comfortable asking their doctors those questions. So we need to ask, you know, what are your wishes? What are the treatments that you feel would be valuable to you in that? So thank you guys so much for that. So in speaking about, you know, we had the barriers, but now let's go to the side of what can hospitals or medical systems do to help their patients and families with maintaining adherence, discussing goals.
I would jump in. I think our pharmacist brings up a great point, which is that the healthcare team, I think each has a role, and pharmacists are underutilized to explain and contribute. Except perhaps in oncology. I've seen, at least in the best medical practices, where the oncological pharmacist really is playing a strong role in the chemotherapy, because there's a lot of toxicity decisions that need to be made. But in general, I'm at least in chronic mental health, people are making decision that they've been on this medication for a couple of years, and maybe they meet someone and they're looking for a little more emotional range, because some of these drugs narrow, keep you at a very even emotional range, and people decide to go off because they're feeling good, so that decision, if nobody's aware of it, can lead to very erratic behavior shortly after. But if there's an opportunity to have a discussion, to move the time of day you're taking the medication, to pick a less narrowing medication, because you're in a good place, it's safer at that point. All those decisions need to be done in conjunction with your healthcare team. And it's when people don't take advantage or don't have a healthcare team that becomes a problem.
Thank you. Dr. Dove?
Yes, Dr. Stearns, I could not have said it better. I was talking to Shane offline about how pharmacists are definitely underused. And I personally think that a clinical pharmacist should be on every medical team, in every primary care practice, in every outpatient setting to address medication adherence. I can't tell you the number of times when I've seen a patient come into the clinic and maybe the healthcare, and this is not to say anything against healthcare providers, the healthcare provider maybe adjust their medication because they aren't meeting their A1C goal or meeting their other lab value goals. But that's not the issue. The issue is not the medication needs to be adjusted. I can easily look in the pharmacy system or look in our EHR and pull their prescription field history and see this patient hasn't been taking the medication. And that's something that I can bring to the table as a pharmacist. So we're definitely being underused. So I think recognizing the pharmacist consistently as a part of the healthcare team can definitely add value and promote medication adherence and use us, because I can't say enough about this. I know that healthcare providers don't have enough time with the patients. In the settings that I've worked in, the healthcare providers may spend about 15 minutes with the patient. That's not enough time. But when I've come into the room, when I was in the community health center and I've been pulled into the room to assess medication adherence, sometimes I may be in there 30 minutes. And it takes all of that plus some more to just assess the medication adherence, see what are the barriers, and get to know the patient, understand why they feel like they feel. And then not only that, but pharmacists, we need to be reimbursed for this, because there's a big issue when clinics want to bring pharmacists in. Well, how can we pay them? Or how are we going to make money? And unfortunately, money is a determining factor. So if the insurances can start reimbursing us for medication adherence and other clinical pharmacy services that we're not already being reimbursed for, then that would definitely be a great help in promoting medication adherence.
A quick question, Dr. Dove. Do you see, since you became a pharmacist, more, you know, more systems bringing pharmacists in that capacity, or do you still feel like the barrier is as much as it was when you started?
So since I've been a pharmacist, I think more practices are, and when I say more practices, I mean like the healthcare systems, the Dukes, the UNCs, the Wake Meds, they are better at incorporating the pharmacist into certain settings. But then the private practices, I've noticed in other practices, community healthcare, the FQHCs, the federally qualified health centers, a lot of other practices are not good at implementing the pharmacist in the clinic setting to do clinical service, to do the clinical pharmacy services. So I think it's gotten a little bit better, but we definitely have a ways to go, even with the big healthcare systems, because they probably don't have a pharmacist in every place where we need to be.
We have just a comment I'd like to read out just in case people aren't seeing the chat. Glenfield, thank you so much. He noted that primary care physician, who is section head of AMA's alternative treatment, said to him that we need to prove the patient right as opposed to correcting them, right? So that language of, you know, having, to me, what I hear that is, you know, we need to be hearing the patient and their concerns. It's not like you made a bad grade because you were non-adherent, right? That we need to really be open to understanding where they're at, what's going on. So thank you for
I think that brings up a great point, which is that we often have little knowledge of what the patient is doing outside of the clinical setting. And so one of the advantages of putting technology into the field is that first of all, that technology should be enhancing their self-management. I call the work that we do cognitive prosthetics. They're there when help you when you're forgetting and leave you alone when everything's fine. And then they have the added advantage if they're working properly, that the healthcare team then can be aware of when there's a concern and make an evaluation. And with the artificial intelligence that's available today, we can build in prioritization so that the bipolars and the schizophrenics and I guess the very delicate diabetics would come to the top of the attention ladder, and people missing their hypertension medication, for example, we can see them at their next clinical appointment.
Thanks. And Linnet, how about you?
So, I mean, I love what Dr. Dove said. I am a huge fan of the pharmacist as part of the team. Dr. Stearns, I think that some of the technology we use with diabetes is very, very impactful for the patient to see when they chug that 2 liters of Coke because they're thirsty, what happens to their glucose level. I think our and forgive me, I've forgotten who put in the chat, but I think that our words are very important. I have heard individuals check someone's glucose level and say, that's really good. And the alternative is, if it's not in range, then it's not good. And that can be internalized by our patients. I think that numbers are high, they're low, they're all great because you checked it and you now know you have some data. It's just a data point. A blood pressure that's elevated, it's a data point. Now we have some information and we can go ahead and fix that. So I feel like our words are very, very important. There's a lot of shame and blame, especially surrounding type 2 diabetes. Or I have heard, I'll say somebody in my household say, oh, they have lung cancer. Do they smoke? Well, come on. Not everybody that has lung cancer smoked. And if they did, that's water under the bridge. We can't change that past behavior now. Let's go forward. What can we do going forward? So I think that our words are very, very important. and a lot of times when I'm seeing somebody for the first time, say it's someone that has come back, that has been diagnosed with diabetes for quite some time, they come back into the hospital due to non-adherence, I'll talk to them and say, how can I help you? What do you need from me? Do you know what happened? And we can talk through some of those things versus, well, you're 16 years old and you just didn't take your insulin. Being able to identify how we can avoid being hospitalized ever again with diabetes, for example.
Thank you so much. That's great.
I'd like to jump in there and say that that comment really sings to me because what's really important is having a lot of data. You need to see the variance in the patient. You need to see what their mean levels are, so that we can understand when it's high and when it's low, which is a very individual number, and that it becomes even more individualized the older the population we're working with.
Yes.
So that we, and this is something that I think medicine in general is not very good at. If you have a 139 systolic pressure, then you're fine. And if you have a 140, you're hypertensive. It is a craziness in my mind, because we know, for example, that number climbs higher as we get older, and it's in some people it's very low, some people it's very high. Now that's not to say that there isn't hypertension and that we need to understand that, but it is to say that we need to be conscious of individual differences, and we need to understand how people vary, and they need the tools to do that, and the medical team needs the tools to see that as well. And another point I would make is that when we're talking about medication adherence, for example, we knowing that a prescription was filled 3 weeks late or 4 weeks late doesn't really tell us how well the patient is doing. We need the kind of tools that so that the patient and the doctor are seeing exactly how the person took the medications, rather than how they did yesterday or in the last 7 days. So these are also, I think, important.
Great, thank you so much. And part of the conversation too, as far as, again, asking if you see changes, what was going on in your life that week, because we know stressors and all those other things can impact things above the medication. Somebody may be adherent, but again, the stressors going on in their life could impact certain things because we're more stressed, so our blood pressure's up or other things are happening. So thank you so much. So I know some of you, you all kind of spoke to it, but like my second question from that one is, if you had a crystal ball, right, what would you like to see happen in the medical community to help patients and to help, the team themselves, right, the medical team caring for them? Because the people that I've worked with through the years, they have a crystal ball and they know we've got to fix things, right? So I think we're speaking to everyone to say, hey, what can we do to help this? Not only the patient, their caregivers and loved ones, but the teammates at the hospital, the whole team. Well, I can't remember who's next? Linnet, you start that one. Sorry.
So, oh gosh, I want the medicines to be free. I don't want our providers to be sifting through what is formulary on your insurance and did we have to do a prior authorization for this. I just want it to be free. And I understand that healthcare is a business. I do, but if we could be appropriately compensated. If the providers and the pharmacists and diabetes educators and everyone that's on the team, our healthcare techs, our MOAs, could be appropriately reimbursed, with living wages, and the medications are free so that people don't even have to worry about it. That we have an extraordinary amount of time to be able to sit down with patients and do either the teach back with each patient, and be able to say, okay, so this is what we've asked you to do with your hypertensive medication. Tell me what you've heard. What are your plans tonight? What are your plans for next week? And have that opportunity to improve their appreciation for what we're asking for. Having that ability to literally sit down and say, what do you want from me? How can I help you? You've come to me for a visit. How can I help you? I just feel like time and money are always at a premium, and we don't have enough of either. And being able to go back and check in on these people 2 days after they've left your office or left the hospital. I am fortunate that I'm able to do that with my patients, and I call them and see how things are going. And it is very surprising to me, the things that we have spent several hours talking about in the hospital didn't quite sink through. And when they got home and looked at their sensor readings or tried giving the insulin after the meal, 30 minutes after the meal, that it didn't work very well. It's another opportunity to circle back and answer their questions. But I do think that access to the medicines being free and having just an extraordinary amount of time to build, and building that team with our pharmacists and our exercise physiologists and our social workers and our nurses to be able to support these individuals.
And I thank you for bringing up the point of asking them what their goals are, right? We need to understand what that individual goals are for their own health, right? They may not be what the medical team feels is correct, but again, asking them what their goals are could help build that rapport and trust and move them into the direction of building that relationship where there's the trust and the plan is both the medical team and the patient. So thank you for bringing that up. Dr. Dove?
Well, I've already stated it. If I could get anything I wanted, the pharmacist would be consistently recognized and included as part of the medical team, and we would get reimbursed for the services and the value that we add.
Thank you. Dr. Stearns?
Well, for me, I think that a lot of the barriers are due to a lack of interoperability, and that is going away. So there's sort of a persistent 10 to 15% that are either on the wrong side of the digital divide, or their attitude is very anti-technology, but technology is the way to get at least a vast majority of people to be connected to the healthcare team, to be monitoring, to produce that variance, and so that we can draw individual lines that when things are too high or too low. And I think when we have the confidence of our technologies that are deployed, say nearly universally, then we free up. If you have 60 people in your caseload, which is a lot for a social worker, that 50 people are fine, and that this one person needs help right now, and the others you should be keeping a close eye on. And now you can adequately handle, and with confidence, more people, and that's how we get how we create more healthcare delivery with the same number of healthcare providers. And in doing that monitoring, I agree, if that's reimbursed, then we have the dollars available to give to our healthcare providers to take care of those people, and then we're getting to them sooner so that they're not in a crisis, they're not in an ER, they're not recovering in a hospital. They made a decision that maybe wasn't a great one, and then we can have a discussion about it and figure out what the goal is and make a conclusion that keeps them healthy but lets them follow in the direction they want to go. So that's my vision.
Thank you. And actually, this is a question I think I should have asked on the barriers, Dr. Stearns, but do you find providers and patients and families sometimes resistant to the cognitive prosthetics that are coming out, the new technology? When you think of people who are in their elder years that, don't even really use a computer, do you find that that's a barrier?
Well, the evidence shows that 85% of people who are 65 to 75 now have smartphones, for example. I think there's an economic barrier. Surprisingly, about 60% to 75% of people with chronic mental health conditions who are on disability have smartphones today. So they're either, sometimes that's being supplemented by the family, but I think as expensive as the very best smartphones are today, the ability to connect to the internet on your phone has provided a great deal of positive benefit, particularly to those in the lower socioeconomic status. So I think that's only going to get cheaper over time, and so I think that you shouldn't be biased that people have a resistance to technology because they're older.
Right.
I think we need to remember that there are accountants who are now 100 years old who were using mainframe computers long before we were born.
Yeah, great. Thank you so much. So the next question, we'll start with Dr. Dove. What are resources that are helpful that could be at no cost or low cost? Anything that you're able to share with patients and their loved ones, caregivers?
Yes, so the pharmacy already, many pharmacies already have measures or programs, initiatives in place to promote medication adherence. We have the adherence packs, and they go by different names, but we can package medications in special packs to help patients remember to take it, because we know that once patients start to take several medications, it's hard to keep track, and sometimes you can't remember, did I take it, when I take it? And so many pharmacies have these special packages where you can put the medication and you can see what time of day to take it, what day to take it, so you can easily see, did I take it? And apparently there have been studies that have shown that just these packages can improve medication adherence. Pharmacies are also doing the automatic reminder text, phone calls, emails, and then some pharmacies are even doing the manual or live phone calls themselves. So pharmacies are already having certain things in place to address this, but we can definitely improve.
One of the things I noticed during COVID is a lot of pharmacies were offering free delivery, and especially with people who don't have transportation. Do you feel that that would also be something that would help adherence for people? Because if they can't get to the pharmacy, how do they get the meds? Do you see that happening more?
Somewhat. I think that really came out because of the pandemic and patients weren't coming in, and the pharmacies knew, okay, we have to get these patients the medications. So I'm not sure if more of that will happen in the future now that, we're not, things are different now. But I do know that we have the Amazons now and other mail order pharmacies that have really stepped up. Well, they've already stepped up, but that are more willing now to step in and mail patients their prescription. So I don't know about the retail pharmacies and them doing more with it, but we have online and mail order pharmacies that are doing that now.
Which helps. One of the concerns I've had is if somebody has a new med and they really need it, like the mail order can take some time where they need to start taking that immediately. So that's why I had people in my work when I was in the hospital be able to have it delivered. So that was a great service though.
Yes.
Lynette, how about for you?
So kind of talking about the delivery, one of the things that we do for our patients as diabetes educators is we make sure that they have everything that they need when they walk out the door, when they're discharged. They have all of the supplies, and there's 9 different prescriptions that we write and get filled for these patients before they walk out the door. And we've recently developed a nice relationship with the hospital pharmacy that they will ship to people's homes free of charge. They don't ship free of charge for all of the patients, but they know that they've developed the relationship with us. So I love that. And I'm going to just tell you, I have not had enough coffee. Please remind me, Beth, what your original question was.
No worries, it's early. What are resources that are helpful, especially that are at no cost or low cost to help people with adherence?
So lower cost insulins are becoming more prevalent. There is legislation in front of the Congress that is not exactly what I'm hoping for, because it does just address Medicare. It doesn't address some of our commercial insurances. But there is a big advocacy push for lower cost insulins. So that's one of the things. We have a good, my partner and I have a good relationship with some of the different other companies that are providing resources for sensors, glucose sensors and meters, so that people have that opportunity to be assessing what their glucose levels are. The sensors can be communicated directly to the physician's office if the patient is interested in that. Unfortunately, some of the smartphones that Dr. Stearns was talking about don't communicate with some of the sensors. So that's a little bit of a barrier. And part of the issue is for that piece is that we need to make sure that the patient data on the continuous glucose sensors is safe. So therefore, we can't just open it up to any phone, any smartphone. It does have to be specific phones that can protect the patient information. And we continue to work on this. I will tell you that our services in the hospital are totally free. When I was working outpatient, the cost of our services for diabetes education was very, very high. And so we had to work very, very carefully to get the services trimmed down. People told me it looked like they had open heart surgery when they got the bill for coming in to see a nurse, and that didn't sit well with them. So I think that people our administration is more aware and appreciating the fact that what our educators can do can reduce readmissions, and that's a bottom line money thing.
Thank you. Dr. Stearns?
Well, I think the question is that I keep thinking is free to who, and I think that everything has a cost. So 7-day pill boxes and pill packing, for example, they both leave the patient vulnerable to overdosing. If there's a packet that you missed lying around, it's very tempting to want to catch up. And we see this particularly in patients with mild cognitive impairment, that those systems aren't necessarily good systems for them. they'll get ahead, they'll overdose, and they end up in the hospital. So there's a cost, so there's a cost. And I think that often when we're innovating, we find that we're saving money for one part of the organization, but we're a cost to another part of the organization. And so even though we're saving overall dollars to the system, there's barriers to the hospital procurement division spending more dollars on technology. That's where the benefit is reaped by the chief financial officer or the physician team in that respect, and not necessarily reaped by the patient. I thought this example of diabetes education is a really good one, because here there's clearly a savings to the system, that you're not being readmitted to the hospital, that your chronic disease is well managed, but that is being borne by the patient rather than the system that's benefiting from it. So, I think as we move towards more capitated models where every patient has a dollar associated with them, and that's given by the government, perhaps as a single payer, to the hospital system, then we have the opportunity to really build all the efficiencies we can envision, efficiencies that no one anywhere in the globe actually has worked out perfectly. So, but I think technology will help close that gap between our desire to essentially have free healthcare that we experience, but at a cost to our countries or to the globe that is manageable.
Thank you. One of the things is, again, going back into my work, which to me is at no cost, is, most of us go to the doctors by ourselves, but to encourage people to have someone, whether they are completely lucid to having some small minor cognitive deficits where they can still take care of themselves, encourage them to have that person that's a healthcare agent or who they feel safe with to come into the doctor's office to understand the medicine, to help them understand how it works, so that hopefully there are less of those overdoses, to help them have that partner to partner with them in order to safe in taking the medication. So you definitely bring up a good point, Dr. Stearns. And my hope is that more times we can even add to the conversation. Is it possible, even if they can't come into the doctor's office, call them on the phone, have someone there with the technology of FaceTime, their face can even be in the room, right? So thank you guys so much for everything. We're kind of leaning toward the end of the hour. So I would love to actually, can we bring any questions? Does anybody have any questions they'd like to ask? I'd love to address those. Anybody at all? Any questions are on the table too.
Well, I'd like to say that I really appreciate having the chance to hear the perspective of the other panelists today, because it was it's great to include all the perspectives here.
Right, and I've loved this panel because it is very different directions of care. So we thank you guys for agreeing to be a part of this.
Thank you for having us.
So we appreciate it.
So there's no question. Virginia said no questions, but wow, that was a fantastic discussion. Thank you all for speaking with us and educating us on what's important. As we're closing up, I'd just like to start with you guys. We'll start with Dr. Stearns. Any closing statements at all in the last few minutes that you might have that you can offer?
Well, I just spent a week earlier in the month in South Korea at the International Society of Gerontechnology's World Congress, which we hold every 2 years. And I got to see cutting edge care that's going on in Korea, but it also looks very much like the best of care elsewhere. And so it's not available everywhere, but I know that I think over the next 10 to 15 years, we're going to see a real blossoming of support systems, and that this interoperability that keeps sensors only talking to two phones is all going to go away, and our EHRs are finally going to open up and bring a lot of new knowledge that makes it easy for the pharmacist to be involved, and the psychologist and the psychiatrist, so and the nurse. So I look forward to that better world when I am old and need the help.
Thank you. Dr. Dove?
I just like to say that as when we're talking about strategies for treatment adherence, we don't want to forget to address the barriers to adherence, because we can spend a lot of time, bringing in a lot of the fancy ideas and everything like that. But are we really addressing all the barriers, or maybe not even all, but the common barriers in the groups that we're serving?
And those are broad. To me, that's one that we can do again, that just address those from the point of health literacy to cultural to spiritual to all those aspects. That could be another hour. So thank you so much.
Mhm.
And Linnet?
And I'm just going to ditto Dr. Dove and Dr. Stearns. I just, I appreciate listening from the different perspectives. And I think that we just need to be very aware of our patients, where they're coming from, where they want to be, and help support them and work to find the resources that can support them in the best way possible. And I just, again, I appreciate you, Beth, and Virginia for getting this put together.
And I have a whole other team of people as well, so behind us. So thank you so much. So we so much appreciate it. If anybody else has questions, we'll stay on for a few minutes since we're on till 9:30. But again, the coalition really appreciates your time this morning. Thank you so much.